So good afternoon all. A really warm welcome to this afternoon's webinar based on the focused site management model with overarching principles for site management. My name's Andy Aldridge and I'm an improvement manager with the ECIST team. I'm joined by a number of colleagues today to deliver this webinar. So we've got Helen Krysinski, Marie Herring and Crystal Skinner from ECIST on the call as well. And we'll share the presentation between us. Just a brief piece around housekeeping on Teams. We're all well versed in using Teams nowadays, but just a brief bit around housekeeping. So what we'll do is we'll deliver the presentation in its entirety. First of all, please do feel free to put any comments or questions in the chat box. We'll be monitoring the chat box throughout. And we'll run a Q&A session at the end. The reason we won't take questions throughout is that there is a risk in doing this that we don't actually get to the end of the presentation. So we'll do the presentation and we'll do a Q&A session at the end. But please do post any comments or questions in the chat box as we go through, and we'll monitor it and pick it up. What we would ask is if you're on and you're speaking at any point, if you could pop your camera on and just do a very quick introduction, who you are, where you're from, before you raise any questions or any comments. That'd be really helpful, thank you. When not speaking, we'd ask you just from an interference perspective and so that everybody can hear, if we could keep microphones off when you're not speaking, again, really helpful. And as you've probably seen, this is being recorded and we will share the presentation at the end of the session. So that's the brief bit around housekeeping from my perspective. Next slide, please, Crystal. Perfect, thank you. So you can see there that focused is a mnemonic, and I won't read it verbatim, but you can see what the focused mnemonic stands for there. What we plan to do is, as we go through the presentation, is go through these in a bit more detail, so that we'll put some kind of flesh on the bones of that really. What we do know in healthcare is that one size rarely fits all, if we're honest, largely because the variables are so wide ranging between hospitals. And that's never truer than in site management. So for those of you on the call who work in site management, you'll know that one size doesn't fit all. The purpose of the focus model is to pull together in one package an overarching set of principles that can help you develop and build your site management model. What I'd say at the beginning is, as we go through it, the model isn't intended to be a structure for your site management meetings verbatim. So it's not an agenda for a site management meeting, although it can be used to pull your agenda together, but it's an overarching set of principles. That's what I'd say. Okay, next slide, please. I'm going to hand over now to my colleague Marie Herring.
Hello everybody, and welcome today. And as Andy said, we're all passionate about site management, clinical site management, patient flow, whatever you call the function within your organisation. And over a number of years, we've developed some of these principles together. We asked one of our friends, a lady called Sonia Noshin, who some of you may know or may recognise as a AKA name on Twitter as Sonia Sparkles, to do a visual for us that actually might start to attract. Some people find some of the principles quite boring in its essence, but actually Sonia's made a really great job here of pulling together a poster for us with the mnemonics down the side and the principles. So please, when you receive the presentation, please click it and make it bigger and use it however you may in your office to make the principles well known within your organisation. But thanks to Sonia Nashin who did this for us. And again, it's one of our ECIST things that Sonia's done a few of these for us on Safer and Red to Green and other things. So please look them up on our site if you find them useful and easy to use. Next slide, please. With clinical site management, it's something that's evolved over many years, and those of us like myself who's old enough to have been around for a lot of years will know that it's actually the poor relations in a lot of services that we have. Often we would redeploy staff there, and it was seen as somewhere where we could fit people that were old ward managers that maybe had some issues with being fit enough for the wards and things. But actually It is massively complex job, very challenging job, and requires lots of different skill sets, knowledge and experience of people that are undertaking those roles. The roles tend to be split into two different roles, one around patient flow, which is the one that predominantly takes emphasis, but the second functions very often around crisis management, surge management. And as ECIST, when we come on your site, we will be looking at your clinical site, the role of the clinical site and how they function, because they tell us an awful lot about your organisation and around the heartbeat of your organisation and the pace at which it works. There are two theories that really important in clinical site management, and again we want to start raising the complexities of these. But once human factors, and in health we're quite commonly use human factors. It's something we've used in risk management for a long time. But in terms of these, all of these principles are important when you're putting up clinical site management. So the person one, for instance, we often have clinical site managers working 12-13-hour days, consecutive days, and fatigue's a big issue. So we need to address how we manage that. Also, the prevailing culture of your organisation is massively important. And as I said, we learn a lot about your culture and leadership of your organisation by just observing how your clinical site management functions and goes. So please, again, we're not going to go through the slides verbatim, but consider these when you've got your clinical site management team in terms of how do you think these affect your clinical site and how do they interact. Next slide. The next side's chaos theory, and anybody that's worked in clinical site management and supported clinical site management will know that the people in clinical site management work in chaos quite a bit, and quite a lot of variability, unpredictability in terms of what they want to do. We're not going to click on these links to save some time, but again, when you see the slides, the Jurassic Park one is quite a simple clip that explains chaos theory to you. Chaos theory in terms of the butterfly effects, which was founded by Edward Lorenzo in 1960 when he was working with weather, and he was talking about how small variable changes like the butterfly wings can have on the unpredictability of predicting weather. So it's small changes on things. Now, when you think again of the complexity in clinical site management and the issues that they're dealing with on a day-to-day basis, that massive amount of unpredictable stuff that needs to be worked through by your clinical site team, and there's some simple tutorials in there if you've not come across it before. But again, in essence, disorder is a disadvantage, so order is advantage of this. And as Andy's already said, we are trying to give you some order, structure and form to clinical site management in the future and share some of our experiences with you. Next slide. Along with that, for clinical site roles is the complexity of not just managing their team, but actually in the interactions of their whole team. So we've just put here some critical coordination rules. In terms of the emergency department, they absolutely need to be part of your clinical site flow in terms of your bed management and flow, and all of those roles, the consultant in charge, the nurse in charge and a patient flow coordinator are critical to help with the communication between that busy department and your clinical site flow. But also in terms of your clinical site flow behind that, then these roles are critical. And alongside that, as you will find through some of the things, we need to understand what your gold, silver, bronze kind of management is with that. But the day-to-day operational function of your normal clinical site management requires the support and influence of these key people in your organisation. Next slide. So for this, I'm going to hand back to Andy, who's going to take you through some of the principles. But again, any questions, happy to take them at the end of the session. Thank you.
Thanks, Marie. Okay, so we're going to get into some of the detail now around what's under each of the letters of the mnemonic, really. But as we've already said, the focus model is an overarching set of principles. It isn't a site meeting agenda, really importantly. The idea of the set of principles is that we start to reduce variation. Now, the idea of reducing variation, and this will be obvious to quite a lot of you who are listening here, but is we have different people working on different days within site management and within the clinical roles within the hospital. And the idea is that we reduce that variation and we have a business as usual approach. And I think that comes up on a few slides as we go through, really. It also works as a really useful checklist, really, to look at key information, and it should enable intelligent data-driven decision making. Really important. You know, we want to make decisions based around the data that we've got in front of us, and that's one of the variables that I referred to earlier as why one size doesn't fit all, because not every organisation has the same set of data. But data is really critical. It also allows for forward planning, and it also allows good escalation and, really importantly, good de-escalation as well. Vital element, really. And the last point you can see for yourself, provides key elements when deciding on site management processes and information required. Next slide, please. We've seen that slide before, so I'm not going to dwell on that. It just gives you the mnemonic again. But what we'll do now is we'll go into some of the detail. Next slide, please, Crystal. What I'm not going to do is read every slide out. They're quite wordy slides, and there's a lot of detail in there. Make no apologies for that. There should be a lot of detail in there, really. But what I'll do is I'll give you time to read it. The first one, the F, is the front door, obviously. Okay. Now, one of the key things that will come up again and again during this, and again, a lot of you will know this, what we don't want site meetings to be is purely a description of where we are as a site. Actually, that should be a small part of it, and some of the things that we're looking on the slide at the moment should be some of the descriptive stuff that we should be talking about a little bit, because it sets context for the rest of the site meeting. But it shouldn't take up a massive amount of time. But we do need to set a context of why do we need good flow within the organisation, and some of that data that we're talking about there, today's performance, current and predicted, oversight of capacity and demand, so on and so forth, is really critical. But we want the majority of our site meetings to be action focused. It's really important, and we come on to that as we start to go through the slides, really. Next slide, please, Crystal. So the O is operational oversight of whole hospital constraints. Really important that we understand, if we go back 10 years within site management, a lot of focus of site management was on EDs and acute medical models. And actually, I think as site management has grown as a discipline, and it has grown as a discipline, quite rightly, it started to be recognised, you know, as quite a skilled job. We realised that actually we need oversight of the whole hospital and what constraints are in there. So yes, we want to know what's going on in our ED, of course we do, and where our constraints are. If we've got, you know, delays in ambulance offloads, we want to know that. But we also want to know what's going on in radiology as well. And if we've got constraints there, that could be staffing, it could be equipment down, we also need to know that. And you'll notice at the top of this slide, it says, do you have sight of? So again, and I'm repeating a principle really, but it's important. You don't have to talk about each one of these during the site meeting, but you should have sight of it within your control centre, within your site management office. You should have sight of this as you go through the day, and it's up to you what you put on your site agenda, really. So next slide, please, Crystal. Hopefully I'm giving you enough time to, we will be sharing this presentation, but hopefully whilst I'm babbling on, you've got enough time to kind of read these principles for yourself. So challenge is, the word that goes before that is appropriate challenge, obviously, and you know that as well as I do, but it's important that we have challenge within the organisation, you know, because, well, it's a difficult job and we have to be able to put some appropriate challenge in. So things like, do we have capacity to assess patients in the same place as the demand? Now that could be as simple as within the different departments within the ED, but you know as well as I do, out of hours, site management tend to manage staffing across the wider organisation. So it is around, you know, have we got capacity on all of our wards? Have we balanced out the risk across the whole hospital? So it talks about that as well, really. Are patients on the right pathway? Is the patient being appropriately managed as short stay, or do they require a speciality specific bed? Is the bed request appropriate? So on and so forth. So the C is challenge. Are we putting appropriate challenge in during site meetings, but also, you know, throughout the day as well, really. Next slide, please, Crystal. So the U is understanding actions and agreeing accountability. Really, really important. A lot of site meetings that I go and observe during my kind of role working in ECIST, a common comment would be they're good site meetings, but they're very descriptive, not quite action focused enough. It's really important that your site meetings are action focused, and by that we mean have we got an action? Have we got an owner for the action? It's really important that one person really owns an action and we know who that is. And have we got a time frame for delivery of the action? And it needs that circle kind of closing off. So we've got an action, we've got an owner, we've got a time frame. It needs to be fed back to the site office once the action is complete. Really important. So we want to log actions and we want to circulate the actions to the relevant team. So that should be circulated throughout the day. Actions monitored for progress. We agree OPAL levels, and I think we'll come on to that in the next slide as well. And we also want to know any service continuity challenges and impacts on flow. Make sure that they're discussed and well documented. Next slide, please. So site plan and reporting. It's really important that we're proactive, not reactive. I know you know that, but it's a critical point really. Always have a plan. Always have a plan in place for the next 2, the next 8 hours, and the following day. Really important. We're talking about tomorrow as well as today. I know sometimes we get consumed in the firefight a little bit of today, but we get out of the firefight by planning for tomorrow in part. So really important that we're talking about tomorrow as well. Ensure you've got clearly documented actions. It goes back to the previous point really. But we need to be action focused. The OPAL level should trigger specific actions to prevent further deterioration is a really important point, and it sits within your, well, both your hospital-wide escalation policy, but also within divisional escalation policies as well. So for each OPAL level 1 to 4, there should be a set of actions, and the idea of those actions is that they de-escalate the hospital as rapidly as possible. So if we're on OPAL level 3, we want to de-escalate as rapidly as possible. Those actions should be designed by the people who are going to be delivering them, because they know what they can deliver, but they need to be, when we get into OPAL level 3 and 4, they need to be extraordinary, those actions, because we need to de-escalate as rapidly as possible. You know, we're ramping up risk within an organisation now. We need to de-escalate as rapidly as possible. Next slide, please. Escalation. So the escalation and the discharge, the E and the D, are 2 slides long. There's quite a lot of information there, and again, I won't go through it all, but we need to ensure that escalation plans are followed and normal service delivery is maintained. That's really important, that we maintain normal service delivery. Standard operating procedures are in place and that they're utilised effectively. And again, I've made the point about OPAL levels, but we need to make sure that they're used and that they're workable. Ensure that there's board level oversight for frequency and duration when we're escalating at levels 3 and 4. Roles and responsibilities need to be clearly defined with very clear expectations. And departmental escalation should be reported to clinical site with a timescale for recovery. Next slide, please. We should be using real-time triggers with the appropriate action cards. Okay, ensure that there's understanding of a really important point. Ensure that there is an understanding within the organisation of the interdependency between different individuals, different teams, and different services. You know, the amount of interfaces that a patient goes through as they progress through their hospital journey creates that interdependency. And if one little bit falls down, it all starts to unravel a little bit. So we need to understand those interdependencies. And we need to ensure that there's appropriate and timely de-escalation. So de-escalation is as important as escalation. We don't want to escalate and just stay in escalation. We need to de-escalate as rapidly as possible. Next slide, please. Just take a drink, sorry. Okay, and the D is centered around discharge. So discharge status should be a part of the daily oversight meetings. Patients who were identified, a key point really, early in the day, patients who were identified for discharge the previous day and who haven't gone should be followed up as a key priority early in the day to understand why they didn't go and what do we need to do today to make sure that they leave in a timely way today. We should be generating a list of patients identified for early discharge tomorrow. So that planning for tomorrow piece again comes up. If we understand who's going tomorrow today, it gives us time to get TTOs done, discharge letters done, so on and so forth. Important, we've got visibility of the discharge lounge, actual and potential discharges. Next slide, please. And we need to ensure that the number of discharges today that are pathway 0 and 1 are monitored. So we should be monitoring pathway 0, pathway 1. That there are simple discharges and they're the bulk of our discharges, and we should be achieving them early in the day. That early in the day discharge obviously gives us breathing space, and it gives us an opportunity to depressurize the front end of the hospital. Important that we're monitoring patients discharged before 12, 5, and those that go after 5, that we monitor that daily, and that performance is shared so that we understand how well we're doing. It's about early in the day discharge, as you know. All patients it's important that all patients have got an expected date of discharge, ideally set within the first 24 hours of admission. So once we've got a diagnosis, we should be setting an EDD, and patients without EDD should be challenged. Okay, all board and ward rounds should have happened in a timely way, and we need to have that understanding within the site office. So if they haven't happened, who are we escalating to? And that patients are discharged off the electronic systems by the professional responsible for the discharge at the point of discharge. So we need that point centres around, we need to keep electronic systems up to date and timely. And if we leave it to, just as an example, if we leave it to the ward clerk to take people off electronic systems, it will fall down overnight and at weekends. So it needs to be the professional responsible for the discharge who takes them off the system, because that gives site management services a really good piece of timely information about where we're up to as an organisation. So they're my slides. I'm now going to hand over to my colleague Helen Krysinski, who's going to take us through the remaining slides. You're on silence, Helen.
Absolute schoolboy error. There's an awful lot of information there, and it is how do you decipher that, and how do you focus on what's important to you and what's important to your organisation. So we have developed what we call a self-assessment tool, which is based on the mnemonics of the focused, and it's a set of structured questions that are weighted with impact to make sure that you can focus on what opportunities you've got within your organisation and what you're doing well. So the self-assessment tool is being piloted at the moment, and we are hoping to roll that out within the very near future after a few tweaks, just to make sure we've got it absolutely right. But that will help try and decipher some of that information. You know, it's not possible to look through all of that and think, well, actually we need to do each one of those actions and each one of those that Andy has just referred to. So the self-assessment tool will take you through that with your teams to make sure that you're focusing your improvement and your efforts and your challenge in the right direction for your organisation, because as always, one size doesn't fit all, and it's really difficult sometimes to see the wood for the trees when you're looking at what would have the best impact for us as an organisation to start our improvement work. So self-assessment will be coming out shortly, and hopefully you'll find that as a really useful tool to start your improvement direction and maybe see clear focus on what is important to you and your organisation. Next slide, please, Crystal. And then we've also got the Rapid Improvement Guide, which is just what it is. It says on the tin, you know, it's a Rapid Improvement Guide, which just has the overarching principles and what the focused model is all about. So it's really simple and really quite straightforward to use, but gives you that overview of what we're trying to bring across to you today. And then we'll move on to the last slide, which is the long-awaited Focused Principles of Flow app. So through market research, and it was possibly with some of you on the call at the moment, we did some market research, and overwhelmingly everybody, what the ask was for a one-stop resource, and a one-stop resource that's at your fingertips. Often when we on ECIST go on site, we get asked for exactly what is being asked for in the question. Do you have a standard OPAL status? Do you have an example of a good FCP? Have you got this policy, that policy? And actually we know it's extremely time consuming for each one of us to individually search what's good, to know what's good, and to be able to have access to that to support your development and improvements moving forward. So we are developing the Focused app. It's designed for easy access, and it will be hinged on the mnemonics and the Focused principles. Under each of those mnemonics, FOC, etc., will be a suite of documents, helpful links, videos, and sharing of good practice that will actually be, as we say, be downloadable from your phone. The aim of this, of course, is to have the information as quickly and simply as possible in the hands of the many as we move forward, and it will help you to, to develop your change within organisation. But we do emphasise that one size doesn't fit all, and everything that we're putting on there is in the spirit of to help and guide you. There is nothing, there's nothing more important than including your clinicians, your ops, your support services when you're developing any of these documents. And we often see lift and shifts, that someone sees a good FCP, they lift it and shift it and put it into their own organisation, wondering why it doesn't embed or sustain, because actually it hasn't been developed with your teams and with your organisation. So really, all of this is just in the spirit of supporting, rather than starting with a blank page and trying to reinvent the wheel, and it will give you some structure and hopefully helpful information for you and your teams. And this is a prototype of what it would look like. This is not exactly what it will look like, but it's just an example of what it could look like. So for example, if you push the front door, then you might then underneath that you'll have a suite of headings, for example, ambulance handover SOPs, and you would click on that and have a 1 or 2 or 3 ambulance SOP examples or some improvement guides within that. So we're really looking forward to launching that shortly. And really it is from everybody who's on this call and who attends the WhatsApp calls and our webinars that the ask has been out there, and the WhatsApp gives us a really good idea of what documentation people are asking for. There's over 200 members on the WhatsApp group, and there's frequently asked questions on there and frequently asked support with documents, and we've taken some of that information from the WhatsApp group and transferred it hopefully into an app that will be launched within the near future. And I can see Kate has put any timescales on the launch of the app, and it's a bit of how long is a piece of string. So put it this way, it's with the developers at the moment, and so they're developing, making it look pretty and have additional functions so that we can get some feedback from the users, as in was it helpful, wasn't it helpful, and search functions, etc. in there. So it's a bit of a prototype at the moment, and run with us, and we really appreciate your feedback as we go along, and there is opportunity to feedback on the app just to make sure that we're developing and improving as we move along with that. So what we're going to do now is open to questions, and over to you. Any questions in the chat box for us?
I think that there's been, I suspect you've answered a couple of the questions in that last point that you've made, Helen. So there's been a number of asks around resource, and what we've hopefully demonstrated here today, I guess, is that there are a number of elements now around the focused model. So we've got the focused model, we've got the self-assessment tool. It allows you to see what you're doing well and where your opportunities lie, and then we've got the resource, which is the app that is, we hope, imminently going to be out there. The app will bring about a selection of those resources, but really important that when you pick up on the resources, that you adapt them to your organisation. That's critical. It really is. Just lifting and shifting rarely works, in my opinion. Rarely works. Your clinicians, who, let's face it, are the only people who discharge patients, your clinicians need to be involved in the development of all of these resources, because it will mean something to them then. So I think within the app, Helen, you've answered quite a few of the questions. We've mentioned quite a few times the WhatsApp group. I know I've recognised quite a few names on here of people who are already on the WhatsApp group, but if you want to join, if you're not on the WhatsApp group and you want to join it, it's a fantastic resource, and really importantly, it's your resource. You're what makes it tick, really. And actually the quality of the information that comes up on that WhatsApp group is significant, and the resources that are shared between hospitals. So keep doing it, and if you want to join it and you're not on it, please do. But I think what we'll do is it's 1 o'clock now, we've got 30 minutes. If we take it to a Q&A session, and we'll take a hands up approach on on Teams. So if you put your hand up, and I'll bring you in as and when, you know, as in time order really. So any questions from anybody, pop your hand up. Somebody must have a question. There we go. There we go. Robin, over to you, my friend.
Hi, I'm Robin Jones from Director of Operations, Royal Cornwall Hospital. I will do the icebreaker for you, Andy. I put my question in the chat bar, but I'll ask it here. Do you have a best practice site report from each of the site meetings? And my reason for asking that question is we've gone through a number of iterations, and we have, in my view, what's turned out to be quite a complicated beast that we're now re-reviewing to try and pare it down to what's the core information we need to share across the whole organisation from each of our site meetings every day. And if you've got a best practice example, then I might just pinch that with pride.
But so I think, were you going to come in there, Marie?
Yeah, I mean, it is some of the resources that we've got on the new app that Helen's pulled together. So we will have something that we can share, but I think it's important, like we've said on the app, that we don't necessarily advocate it as best practice. We advocate it as an example for you to use. So we'll share what we've got for that group. Can you do that, Helen? Because you've got all those resources, haven't you?
Absolutely, and it's been absolutely evident as I've been trawling through, as you can imagine, hundreds and hundreds of documents that have been brought forward, that there's usually something really good in every single one. And what is good for you isn't necessarily good for somebody else. So to say this is a gold standard site report may be completely irrelevant from one organisation to the next. And it sounds really woolly, and a really woolly response to your question, because actually, ideally, there should just be one. Why shouldn't we all use the same one? But actually, as you visit different organisations, it is so unique to different organisations. What is important to them? Is it the community? Is it the lack of GP primary care support? Is it the system? Is it our own internal behaviours? Is it our accountability within our organisation? And it just doesn't all fit exactly. Have you got an S deck? Haven't you got an, you know, on all of these bits and pieces? And I know I'm just talking, you know, stuff that you already know, but through my experience, because, you know, obviously when we started doing the app, we're thinking actually we could put all this together and come up with best practice example of our real key documents, but it's not as easy as that. It just isn't.
I think that's a really valid point. I suppose I was probably selfishly thinking of even from a basic layout perspective and then tailor, but no, I completely get your point. Thank you. Thanks very much.
And I think it's worth it. There'll be more than.
Go on, Helen. Sorry.
Apologies. There'll be more than one document under each one of these, so that actually it's just have a look at each one and pull what works for you.
And I think that's the point I was going to make, Helen. I think looking at a selection and picking out the best bits for you and your organisation is the way to go at it. I know when we've been asked before, as we go on different sites, we'll get asked by the Chief Operating Officer, for example, have you got a best practice document? And they're not keen on that one that we supply. Well, actually, the organisation down the road love that one. And the one size doesn't fit all thing just absolutely is true. Marie?
Yeah, I think the point, I think ECIST can come and do some observations, and they can work with you around your transactions. But I think the people that we've got on our WhatsApp group now, and people that have helped develop some of the resources that we've got, is that actually peer-to-peer reviews are often quite good. So I would suggest, Robin, that you link up with somebody else that's on this meeting that's actually got responsibility for site management, and try and negotiate some peer-to-peer review, particularly in the world now where we can do that so remotely with Teams directly observant. Then I find that's the best way to learn from each other and enhance your practice, because yous are in it, yous are dealing with it, and yous know the little nuggets that make the difference.
And the WhatsApp group is absolutely perfect for that. And that's what it gets used for significantly. You know, somebody will put an ask out, has anybody got and the answers come flooded in. It's a really useful group. Can I take something then over to Amy? I think you're next, Amy Barton.
Hi, so I'm the senior site matron at the Norfolk and Norwich Hospital, and it's just kind of in response to Robin. So I'd be happy to link up and share our sit rep and just what we do after our patient flow meetings. We're actually looking at reviewing them, but some of the data and some of the stuff that we do share currently post meetings will stay in our reviewed process. So if you want to contact me afterwards, we can arrange to chat on Teams, and I'm happy to share things with anybody else as well if they want it.
Brilliant. Thank you, Amy. That'd be great. Thank you. I'll take us over to Lorraine Walton, I think is next. Lorraine.
Hi, I'm the clinical ops manager at UCLH in London. I was going to say the same, but we change ours depending on what the demand is. So quite often we'll be asked a question that isn't on our site report, so then we'll add it. Our site report currently is 4 tabs, so depending on how good or bad the organisation is, people can drill down further. So we list all of our patients waiting in ED and SDEC every morning, for example, so that our specialty teams can see what their demand is individually. But we're forever changing ours, and our site meetings now are 4 a day, and they're all on Teams. So we record the actions in the chat, so everybody knows who's taken which action.
Yeah. And I think a really valid point. I think most site reports are always an ongoing piece of work, and they're always an iteration. You know, I think they're a classic example, aren't they, of improvement work, really. They very often are always changing to the demands of the organisation, and as people change in the organisation, so the demands change a little bit, I guess. Oh, thank you for that, Lorraine. Good point. Okay, any more questions? Andrea. Hi, Andrea.
Yeah, I'm one of the clinical site managers at LTHT at Leeds. So obviously we're a big trust, but one of the things that, and you mentioned it about sort of how reactionary, it feels like our role is a reactionary role. You know, it's that crisis management, lastminute.com. And it was just when you mentioned it and I saw it, and I've been thinking about it sort of a lot recently, how we can turn that around as site managers. You know, we go into Silver Command when it's really bad. We come out of it when it's bad, but not as bad. And I just wonder if we should be maybe doing it the other way around and kind of being in Silver Command while we stand a fighting chance of not having such almost crises then to deal with. I don't know if that's just felt everywhere, because I know it's almost like white noise at the moment because it's so difficult. The minute it's not as difficult, we kind of step back a little bit and don't call a silver, and then it gets really difficult again, and we just seem to have kind of got into that routine, really. Yeah,
really good point, and it is in a lot of organisations. You know, and there never is one silver bullet for this. Marie, did you want to come in and comment on?
Yeah, I did. I think that's valid comments that we see up and down the country, and actually that's where some of our sympathy and our hearts go out to clinical site management, because it is complex. However, this framework is about building this as business as usual, and not necessarily being about crisis management. It's about getting your triggers right and learning from your experience, constantly reflecting and looking at the framework, because the information and the early signs will have been there about you tipping into escalation. And it's about, I'm not saying that every time you can do something, we're not blue sky think and green grass people, so we do know that there will be surge activity, but there are plenty of times when actually the triggers and the signs were written before we've actually responded to them. So use the framework as in what can we do as business as usual, and then to apply that in a disciplined way and try to reduce the human variation of the approach to that, because often we see, even when we were talking previously around site meetings, for instance, we all know that people will come into a site meeting and they'll deal with that site meeting differently, even when you've got a perfectly beautiful layout template of how you want that meeting to go. Well, that's about saying, actually, this is the way we do it around here, and we've got this structure and approach for a reason. And just because you may be more senior in the room doesn't mean that you can handle it any differently. We want to handle the meeting in the way that we've got, and if the meeting doesn't work for you, then change the format of the meeting, but live and learn from your experiences, and don't allow the human error and the most senior people in the room to command the situation, because often, again, the most senior person in the room is not necessarily the right person to be making all the actions and the decisions. So use the framework as a means of business as usual approach, I would recommend.
Thank you.
The other bit that I'd probably add into that, Andrea, as well is, and then I'll bring others in. I see that we've got other hands up. The other bit that I'd add into that is you spoke about, you know, we're always at significant levels of escalation. What can we do as site management to kind of pull it back? And I think there is a piece here, isn't there, about making sure that the organisation recognise that everybody's got their part to play in flow. So, you know, I know we all know that site management can't make beds early in the day, because that's not your function. It's not the function of site managers to make beds early in the day, but sometimes there can be an underlying perception that that's what should be happening, that site management should make beds. They can't make beds. We all know on this call that actually it's clinical teams at ward level that make beds early in the day. And it's really important that everybody owns their part of the flow journey. And, you know, the accountability sits where the actions are doable. You've just come off silence. Did you want to come back on that, Andrea?
No, I think that's a really good point, Andy, because the other issue is often if there's a difficult HR issue, or you know, I've done the job 5 years and I've had to deal with some really harrowing situations out of hours, and your mind and your sight is not on flow, it's on that situation. So actually you do need everything else to still be functioning, don't you?
You really do, you really do. And if we go back to the presentation, one of the things I said in the presentation, this bit about everybody has to own their own bit. If we've got action cards, if we've got divisional action cards that sit with the OPAL levels, it's important that the divisions develop the actions, you know, because there is a point here, isn't there? If we say on a site meeting, have we delivered all of our actions for OPAL level 3, and we say yes, well, if we're not de-escalating the organisation, they're not working. And so the division then need to go back and relook at their actions and reconsider, are they robust enough to de-escalate the organisation? That can't just sit with site management. The divisions have to own their bits as well. It's really important, really important. Kate, can I bring you in? You're sitting patiently with your hand up and I'm burbling on.
Thanks, Andy. First of all, that's really helpful comments from yourself around clinicians owning their part of the process. I'm the Directorate Manager for Discharge here at Wigan, and we do find that we are the ones expected to find the beds across site whilst working with patient flow managers. And just really coming back on what Andrea was saying as well, here in Wigan, we find the same, and I know Louise Clarkson, one of my colleagues, is on the call, in that we will go to escalation. We'll start WhatsApp groups, Teams groups, we'll have 4 daily calls, we'll have a system escalation call. That then becomes the norm because we never step it down, and it perpetuates this chaos and this feeling of, well, we can't do anything because this is how bad it is and it's always this bad. And then we've got nowhere to escalate to then either, because, well, that's our permanent state. So I think it'd be really, really helpful to review those action cards that you speak about. But in answer to Andrea, yes, you're not the only trust that experiences that, and whether it's something that we just see in Wigan, but in Wigan we are very solution focused rather than problem focused. So we'll throw everything we've got at it, but we don't actually know what we're trying to fix. None of us could say what the exact problem was. All we can say is, well, I've done this and I've done that and it's still not working, so let's carry on with the calls and the WhatsApps and the meetings and hope something drops out of the bottom of it. I really encourage staff at the moment who are taking part in the Home First programme, even when we're very busy, I do encourage my staff to step out and take part in the workshops and the facilitation that ECIST has provided, to be part of finding that solution, and part of identifying the problem. Because I think if we don't do that, and as managers we don't promote and support staff to do that, then nothing will ever change. We really do need to take those one step back to take 2 forward.
So I think really helpful comments there, Kate, and it just you've demonstrated the point I was trying to make, really, but really helpful. I think, you know, one of the things that we should ask ourselves when we look at the actions that we develop for a division. So let's say for a medical division, we've developed a set of actions that would hopefully de-escalate us back down the OPAL kind of ladder. What do those actions make a difference to what the registrar does, for example, on the respiratory ward? Or does the registrar just continue working and doing the same job, whether it's OPAL level 1 or OPAL level 4? Because if they don't make a difference at that level, those actions, we're probably not going to change anything. So they need to be actions need to be bold, because we've got risk in the organisation, and they need to bring about the change that we want them to bring about, which is a difference in behaviour, a difference in, you know, how we assess risk and how we kind of work clinically at ward level. It's really important. And if we don't think that they do that, they're probably not going to de-escalate the organisation. I think I've got Amy next. Amy's next with a hand up.
Yeah, I just wanted to just offer kind of a bit of reassurance. So obviously you mentioned about finding it hard with the silver command. So we had that issue here, and what we actually did was change our patient flow meetings to be tactical meetings that were then led by our silver, irrelevant of our OPAL status, so that we actually consistently own the ability to give out actions and kind of say which action cards you need to be using, and that actually, depending on the OPAL status of the organisation and the pressure that we feel, we have the ability to enact something that we call triggers from our ED department to our AMUs and out again, and that's run through our patient flow meetings. So we changed our operations centre, just literally changed the name on the door, and it says command and control, and we refer to people as silver. And actually, as an ICS, we have silver and gold meetings with the other organisations locally to us, and that has changed, I suppose, our ownership and then our command and control, so that we don't have that where there's somebody more senior in the room who will then almost kind of try to take control of it, because actually this is led by silver. We have bronze commands for the different divisions, but actually we don't allow anybody else in that meeting. We try to take them out of it and just have a membership only. And actually, if it needs to escalate to gold, then the silver command escalates to me, and then I will take that and we'll have a different discussion. So we try to own it at silver level so that our clinical site manager remains wholly in charge of that whole patient flow meeting.
Yeah, perfect.
I don't know whether that might work across your organisation, but that is how we kind of took our own ownership of those meetings back and allowed us to kind of give out actions directly to divisions and call them back on it at the next patient flow meeting.
So I think great comments, and I agree with you. One of the important things that you raised there, I think, Amy, is thought and consideration going into who attends meetings. I think the attendance list is really important. Who goes and who doesn't go.
Yeah, so we found it quite uncomfortable to start with, because you are asking people that potentially sit on the gold in the exec rota to leave a tactical flow meeting, but ultimately they don't need to be there. So we found that the more people that attended, the more complicated it got. So actually, by saying, I'm really sorry, thank you for attending, but we don't need you, we'll escalate if we do, is really uncomfortable to start with for the silvers, because actually these are people that you would escalate to out of hours, but in ours we have our own gold, we have our own exec. It's slightly different structure, so we had to really take that and run with it. And occasionally people will dial back in, but we will remove them from the meeting. And actually having it on Teams makes it far less stressful as well for people to have to do that. But we just try to do that as our command and control, and it does help us.
Yeah, I agree. And it's that rigor, isn't it? If we've got a standard operating procedure for these meetings and it's agreed by the organisation, well, it's a conversation we're allowed to have now, isn't it? Really important. Okay, thank you for that. Thank you, Amy. Fiona, can I come to you? You've got your hand up.
Hi everybody, thanks. So it's Fiona Sharp, patient flow manager from York. Really similar situation to Kate and Andrea, and useful comments from Amy, thank you. I was going to just ask the same question about attendance at meetings and escalations, because we have been in escalation for some time now, and it is just become business as usual. And I suppose from an opposite for us, the attendance at the operational meetings is more junior staff, I would say. We don't really have much senior involvement, and I was just going to ask how I suppose, what's the recommendation from a matron level to implement these things in the organisation? Where would I sort of go with this to implement? I suppose I can change how the structure is of the meeting, the agendas, but actually we don't have that senior attendance at the meetings, whereas sometimes we do need that. So I think from an escalation point of view, like you said, I can say OPAL 4 action cards, but we're not assured that people are taking those away. So I suppose it's going back to the divisions and about their escalation cards and actions. So it's just any advice on that, really. Thanks.
I think I'll bring you in a second if that's all right, Marie. I think my view on that, and this goes back to a one size doesn't fit all. What's best practice for one organisation isn't best practice for the next. My view on that would be, you know, if I'm running a site management team, I would want the attendance list for a site management meeting to be senior people who have authority to make decisions in the meeting. What we don't want is junior people going to seek permission, because we're losing hours and minutes here if we're not careful, and hours and minutes is critical in patient flow. So we want, you know, senior decision makers who can make, or with delegated authority, but I don't mean delegated authority down to a band 6, for example. I mean senior decision makers for each department, so radiologists represented, whoever you want at these meetings. It'll be different for different hospitals, but senior people who can make decisions in the moment, because you'll find you get more work done by doing that than you do with quite junior people. That would be my view. Marie.
Yeah, thanks, Andy. I think that's really useful to point that out, that the people need to be decision makers and they need to be able to delegate to other people to support the actions that are required to do, and that the actions don't necessarily need to go from one meeting to the next. You might need something done in the next half hour, and the expectation is that needs to be done in the next half hour, and the site team should get that feedback that that action's now done and completed in being able to do that. I think it's really important what people are saying here is about understanding what people's roles is at the meeting. I think it was really interesting around not necessarily needing the senior people at the meeting, but the important thing is that your communication, your escalation response needs to be very, very clear, that I mightn't need you at the meeting, but when I escalate to you, I absolutely need your support. And it's about that being very clear around what the ask is. So again, when you're doing that, use some of the other tools that you've got in your arsenal, like the S-bar, being very clear around what your situation is, what the background is, what's the action, what's the response, or smart actions in terms of what other people use. So learn the art of being articulate around your ask and around when you want that to be done. As a senior person in an organisation, I wouldn't necessarily be upset about being sent away from a group, but if I was on call, I actually would want to be listened to. And again, it's about just being very clear that if I was the senior person in your meeting and not normally there, just that I was here to observe the conversation and the discussion and debate, because I'm the on-call person, and ultimately I am responsible out of hours as well. So so don't necessarily bar them completely, but make sure what their presence and their role is.
It's brilliant, and a good question, Fiona.
Thank you.
Good question. Mr. Stenson, sir, how are you? It's been a long time.
Very well indeed, thank you. How are you?
I'm good, thank you. I'm good.
Good. I was just Marie's just said it really. It's all for me. It's all about defining roles. So if you're very clear that people inside the meeting and outside the meeting have a very clear defined role, which has been published to them, they are made aware of. It actually needs Starlight.
That video, the Starlight video.
Can I just ask somebody's not on silent.
Benjamin.
If you're not talking,
Benjamin White.
Benjamin White, sir. Could you go on silent for us? Sorry.
Thank you.
Andrew.
Yeah, I mean, no, that was it. So I think within your SOP, but also within your training around gold and silver, you're very clear. We need to be very clear what the roles are, what the expectations are, and every organisation that I've ever worked in has got that wrong in one way or another, and needs to
And if there aren't, just give it a second to see if anybody else has got anything. We'll take that as a no. So we've nearly done the hour. You've got 4 minutes back there, guys. How's that? So that oh, Marie Herring.
Yeah, just to say there's lots of people expressed an interest in being put on the WhatsApp group. I've made that list, Andy, so I'll sort that as soon as I can for those people that have put the details in. And also Crystal's put some links further up to things like the ECIST Futures page and the resources that we're able to share at the moment. So if people need those links, they're further up in the chat.
Great, that's great. So Helen?
Yeah, just to say that obviously once you're all members of the WhatsApp, then actually when the app is released and the assessment tool, they will go out via our normal social media routes, which will be, you know, your Twitter, your Facebook, your and through the app, more importantly through the app, because there's so many members on there. It will be it's, you know, it's going to be the power of the people in sharing this app across organisations. And one more point, it obviously will be free and easily downloadable to anybody, including public as well. And thank you for today, and thank you for attending. It's been absolutely brilliant. Really appreciate it.
Absolutely, great session today. Some great conversation, some really good questions. It's been really useful for us, and hopefully it's been useful for you guys as well. So we've captured all the information. I won't repeat what Helen and Marie have just said, but just a massive thank you to you guys for your time. We know you've got difficult jobs, and we know time is of the essence. So thank you for your time today. It's been really constructive, and we hope to see you all again soon. But if you're on the WhatsApp group, we'll speak to you soon. Take care, guys. Thank you.
Bye-bye.
Thank you.
Bye.